I'd like to acknowledge the traditional owners of the land on which we're meeting today. I'd also like to acknowledge all the parents, families, caregivers, the children themselves across Western Australia, in regional WA in particular, and also all of the Aboriginal health staff who work for WACS. Do we have any of them here today? Do we have anyone who works for WACS at all? A few. Yeah, okay. Across WA Country Health Service, WACS, we have a lot of Aboriginal health workers. We've got Aboriginal liaison officers. We've got Aboriginal health consultants, one in each region, who sit on each of the regional executives, which is a fabulous, fairly recent initiative. We've got Aboriginal health, allied health staff, nursing staff, medical staff, and admin staff, of course, who do amazing work. And that all brings profound richness to the work that we do in WACS. I've worked for a long time in policy and population health, community health, and what I'm going to try to do today is talk about the population health screening programs that we run, which sounds fairly tedious, but I'm hoping to get some nice photos to get us through it. Between WACS and CARS, so WACS and CARS are obviously two different health service providers, but we have a joined-up approach to policy. Our practice looks a bit different because it needs to in different communities across WA. We'd have a joined-up approach, but my focus is going to be on WA Country Health Service and regional WA today. Next slide. Can I do that? Yes. No? Right. So in WACS, our screening programs take on the whole regional population health approach, and as you can imagine, our aim is to screen children, all children, offer screening to all children at key points in their infancy and early childhood. And we do that through the child health services and the school health services that run through every community as much as possible. And we offer more contacts and checks for those children who are recognised at higher risk. And I acknowledge my colleague Leonie Helwig, who's sitting in the middle of the group, who has I'm going to talk some of the work that she and I have done together. And Leonie's been a leader in that child health and vulnerable children space. As you're aware, the regional population is spread over a huge area. People live in very remote communities, but we've also got, lots of rural towns. There's mining communities, isolated farms, but also, quite a lot of urban populations. If you think about Bunbury, Albany, Geraldton, particularly Bunbury, Busselton area, it's quite urban, and that brings its own challenges. High diversity and a need to adapt our ear health screening service to meet all of those needs. So I'll talk something about the WACS perspective broadly, and then going to focus in on two local areas where they do a particularly good job. So just a word on screening first. Quick word on what we mean by screening. It's bandied around a lot. My definition is a quick check to see if we can step in early and prevent a problem. And there's the WHO definition underneath, presumptive identification of recognised disease, etc., etc. So that's the official WHO, World Health Organisation definition. So we're trying to obviously get in early, and I do thank the organisers of this conference for allowing us to focus on early intervention, screening, health promotion, all that prevention, which is so important. Population-based screening. So there's not too much population-based screening programs in Australia. There's not many, because there needs to be really strong research evidence around putting that much resource effort into a population, screening the whole of a particular cohort or a population group. And of course there's science around screening, which I'll just touch on really briefly. We need to make sure that it's a reasonable common problem, that it can be picked up by a quick test. Screening needs to be reliable. The screening test needs to be reliable in picking something up. But it's not clearly it's not a diagnosis. It's just looking to see if it's likely there is a problem. Test needs to be acceptable to children and families. It needs to be pretty quick and pain-free and not too much discomfort and not too invasive and appropriate for the age and the stage of our little children. And the intervention and treatment that may be needed needs to be accessible and available too. So there's no point in screening where we haven't got somewhere to refer for something. And that it needs to be effective in actually changing the trajectory of poor health. So there needs to be really good evidence along every step of the way that it's worth doing. And there's not many conditions that fall into that sort of category, but of course we know that ear health is one of the few of that. And in WACS we see ear health screening programs in infants and children as a foundation service to promote good health and ear health. And the starting point for children who need to travel on those care pathways. And we do try and offer to all children. I'll describe that a little bit more at the moment and how it works in terms of the government public, West Australian public health services, so through WACS and CARS. I won't speak for CARS, but CARS try to do the same thing. Of course, the first step is newborn hearing screening, and there we've got a little child. I'm not sure which hospital that child was in. The hospital up the top is a brand new beautiful hospital at Port Hedland, and the one down the bottom is the Albany Health Service, which is recently. We've been able to put a lot of resources into actually improving our hospitals lately. So in Region WA there's about 7,000 births. There's 7,000 children born every year. 4,500 actually born in WACS hospitals. So we do that newborn hearing screening there. Many women choose to have their babies or need to have their babies in Perth, and we have systems set up so that we can reach out to them as well. But just for your information, WACS has 19 maternity sites, so we have a very strong maternity service network that's linked into King Eddie's. And newborn hearing screening is mostly handled in the hospital settings, in some cases into the community, but mostly in the hospital. Child health services. Many of you will have had experience with child health services, I'm sure, one way or another. So in WACS and WA, there's a universal child health service, which I'll explain, offered to all families. And the support is around parenting, and to enhance child development and early detection. And hearing and ear health is just one aspect of that. There's a systematic process where, and I've just described this one on the left, is a nurse working with a little one in Yilgargina, which is in the Midwest area, a community in the Midwest. And the one on the right, I think, is down in Bustleton. Is that right, Leonie? Okay. So whenever there's a child born in WA, a birth notification is generated and sent to the local child health service, and we've got systems that handle that. So a child health nurse can reach out and make a phone call to the family, the caregiver, the mother, as they come home from hospital, and then make a visit within the first couple of weeks and gets that relationship started, helps with some of the maternity and child health issues that are happening in those very early stages. For ear health, at this stage it's really just checking that the newborn screening has been done, and asking about the results and seeing if there's any follow-up needed. And then there's some hearing surveillance questions that parents are asked in that early stage around, does your baby jump to noise? Does your baby cry at very loud noises? That sort of hearing surveillance questioning without actually looking in the child's ear at this very early stage. And asking about risk factors for the family, the pregnancy that might impact on hearing. At the 8-week check, it's rather similar. There's surveillance questions for the caregiver. And I do need to let you know that child health nurses are compulsory in some areas, but absolutely voluntary in Western Australia. So as much as these are offered, and there is some really good uptake, especially in the first couple of appointments, I'll tell you a little bit more soon around how that falls away, which is a little bit of concern. So we also work with a lot of art shows, and I know we've got some people from art shows here today. Many, put your hand up if you're from a Aboriginal Health Service or few, okay. And WACS has contracts with a number of the art shows so that we can, I know in the southwest and quite a lot of remote areas, places like Walloona, a number of places in the Kimberley and the Pilbara, where we contract and work closely with the art shows so that we have that our service, our community health service, extended out to those remote communities. So this is what it looks like. In terms of universal contact, that blue down the left side is where we offer all families. So there's those 6 points of contact. And then in terms of hearing screening, they really starts at 8 weeks. The first contact is screening questions. And then for all children, there's screening questions. But for Aboriginal children, since the Auditor General has advised that we should, we have started to, we well and truly implemented doing some otoscopy, the physical health checks, otoscopy and tympanometry checks for those children from 8 weeks. And that's been fairly challenging to implement, but we're getting there. And that goes on for Aboriginal children right through those contacts. We're still working to get some of the child health nurses upskilled with both otoscopy and tympanometry. We got interrupted by COVID this year, and as those of you who do those checks know, that practice is required, and repeat practice and experience in not only doing the test but interpreting the test. So we've still got some work and training to do there. The other thing that's really important is, of course, those key education messages that are shared with families, with communities, with caregivers, with schools as well. But at any time, parents can come back, and if they've got a concern, they're welcome to make an appointment with the child health nurse. Numbers are still recovering, but in 2021, that first 0 to 14 2-week check was 93% of children had that check. 8 weeks, it's around 80%. 4 months, it's down to 70%, and by 1, it's around 60%. So we get a bit of a drop-off. And by 2, we're seeing under half of those children in terms of WACS children. So, you know, that is something that's a limitation to our service. It's not voluntary. We do our best to entice people back in, but some parents choose not to come. School health. This is a major population screening program in WA. School entry health assessment program, and it has really exceptional reach. We go into all the schools, and hearing and vision checks have long been part of this program. The community health services work in schools, so there's really good partnerships across anywhere where children go to kindy and pre-primary in all of our schools. And the nurses work closely, and other staff work closely with kindy and pre-primary teachers in particular. So parents are invited to provide information, written information or over the phone about their child. There's a health questionnaire, and then the teachers help prioritise the kids that they think need early assessment. And about at least 96% of children get this service. There's a small percent that aren't attending school regularly. There's a small percent that is difficult to contact one, and there's a small percent also these screening tests is not suitable to do, and some parents decline, but 96% is really good reach. That's, you know, children across regional WA. And for some of those children, that relationship with the nurse continues for some years, some months and years, as they, you know, if there's an issue that's turned up, or there's a follow-up assessment requiring, or helping them negotiate the various referral pathways that they need to pursue. So for some children, this is quite late. They might not have had an assessment since they were born, or in those early weeks and months of their life. And, you know, we know that that's too late, but at least we're trying to get in and prioritise those children as soon as they turn up at school, because most children do turn up at school. This is what we try and do at the school. The school entry health assessment is that big population program, and all children we do otoscopy. There's screening questions, there's otoscopy, and there's audiometry. And typically the nurse will talk to the child, and there'll be some understanding of their speech and other development. So it's sort of not just hearing in isolation. There's a whole lot going on. For Aboriginal children, we also do tympanometry there as well. And the nurses who work in that school health assessment program do hundreds of thousands of checks. They're very, very good at doing these checks and working with the kids and working with families and working with the teachers. And in pre-primary and year 1, we also try to get to all the Aboriginal kids, come back to the schools and see the Aboriginal kids. And I know that works better in some places than others. But at any point along the way, during the school years, if screening is indicated, sometimes the kids indicate themselves that they need to see someone. But usually it's the teacher or the parent who does the referral back to the nurse. And there's always key messages, and there's health promotion that happens in some of the classrooms as well. Either the nurse advocating for that to happen, or partnering with a school, and a lot of schools will, very keen on helping the children, and will do some sort of health promotion activity to prevent and also support the children that already have some hearing loss. So just a word on the WACS Enhanced Child Health Schedule. We recognise that some families need more checks, and so we offer up to there's 16 checks there, and that's the child health nurses, school health nurses, community health nurses will actively, and also the teams, Aboriginal health workers and so forth, will actively follow up. So the ones down the right-hand side are the universal checks that all children receive. The ones down the left-hand side or down the main centre are the additional checks that we try and offer, or we do offer to all families in regional WA. And these focus, some of those checks, depending where the child is, will look at social determinants. There's a focus on ear, eye and oral, respiratory and skin health, nutrition, development. Regular development assessments is core. Right, some of the challenges, I've already alluded to this, but not everyone chooses to accept the offer of service, and that brings its own challenges. Some people go to their other providers, their local Aboriginal Health Service, or maybe their GP or other providers, and that's absolutely fine, and they're right and good. Staff vacancies across WACS do interrupt services sometimes, although these are prioritised, these sorts of population health programs, but we do have staff vacancies, and that's been an issue even more so in the last year. Coordinating services for families that need support is an ongoing challenge, and I'm going to describe a couple of the local teams that do it really well. A lot of work's gone into these programs and around trying to make things really practical and culturally acceptable. People give a lot of thought to it, and there's a lot of Aboriginal health staff who have input, but also community members that have input into trying to reach out to our local community, so they do offer take up the offer of acceptance and come in and have their children's ears checks. And a lot of strong partnerships have been formed. This pair and as a photo I took in Narrogin Hospital of a mother with her child and the child health nurse. So many of you would have heard about the Goldfields Ear Health Screening Program in the form of the Pinagabi project, which has run over the last couple of years, which is now evolved to be core business in the Goldfields, which is fabulous, at least in Kalgoorlie, and they're looking at trying to spread it across. And I've talked to, and I'll acknowledge Ruth Monks. Many of you will know Ruth, who is the clinical nurse who was central to the Pinagabi project and is still working up there, slaving away up there. I think she's on holidays at the moment though. This program focuses on, some of you will know, it focuses on supporting families when they come in for immunisation to do the ear health checks. So rather than relying on families coming along for their child health checks, they've decided they'll jump in and offer ear health checks when children come to the immunisation clinics. So the families are responding to the incentives to get their children immunised, so it works well to look into their ears at the same time. So we've done a lot of training and support for the staff who actually do the immunisation so that they can do the ear health checks. And the checks are actually otoscopy and TIMP. And the child health nurse and also the Aboriginal health workers will do those follow-ups and support for the families if they need it. And there's a lot of coordination around that for the families that need to follow a care pathway. Just wanted to make a note of the 3 archos that we work with in the WACS Goldfields area, in the Nanetara Land and Wiluna area, and down at Ginginjara as well. So they extend our community health services into some of the remote communities, and that sort of really exemplifies how we do that in our regions. Here's that's Ruth on the right. Beg your pardon? Yeah, yes. Doing an otoscopy here. So at the immunisation clinics, and this is actually in the clinic in Kalgoorlie, strong support from the clinical nurse Ruth. So she's now working with community health nurses across the whole of the goldfields to upskill them in using, otoscopy and temps, particularly with the child health nurses and the younger kids, from 8 weeks using that 1,000 hertz capacity tympanometer. And at the universal contacts, and also that enhanced child health schedule that I mentioned before. Ruth works with all the school health staff as well, and they're doing a great job getting out to all the children as they enter school, looking in their ears, and doing that annually for children, for the Aboriginal children. And there's a lot more work. As I said, they put a lot of effort into the screening, so they get that platform across the whole population, but also supporting those families that need to access services, whatever that might be, speech pathology, more assessment through an audiologist or GP, and of course ENT. So there's a really strong focus on, as per the national guidelines, and really strong partnerships. I think that's that's the thing that Ruth was most keen. She's put it in bold capitals, strong partnerships. So there's a lot of work with the local community, the local Aboriginal medical service, and the GPs in particular, and ENT services at PMH. So, and that's always, that's just to mention a few. Next one I wanted to talk about, and I know that this team at the WAX Wheatbelt Aboriginal Health Team has presented at this forum in the past, but this program is focused on health promotion and early intervention. So it's got the screening element, but they've really decided to try and get in and do health promotion and actually prevent things that are going on with Aboriginal children in the Wheatbelt. The Wheatbelt in WAX, we've got 2 Aboriginal health services of our own, one in the Wheatbelt area and one in the Great Southern area. So that's a wonderful thing for our teams, because there's really close partnerships between the community health services and the Aboriginal health teams. And I know that's the case in the Metro Perth as well. So the Wheatbelt community, it was found that a lot of Wheatbelt kids were being admitted to hospital for ENT surgery, well over the WA average. And Aboriginal children in particular in the Wheatbelt 6 times higher than the non-Aboriginal children, and that won't be atypical, but they got the stats and they wanted to act on it in the Wheatbelt. So they did their own ear health strategy in 2020, and they've planned and implemented along the way, which is something I think Anne Marnie and her team have talked about before at this conference. So they're planning, they're just up reviewing that at the moment, and they've got a new partnership with Hearing Australia and the Happy program, I understand, which they're really happy about. And they're also working to expand the telehealth links back to PCH, which last year they started it, and I remember there was some advocacy around it, and they're actually acting on that and trying to reach out to many places in the Wheatbelt so that telehealth is more available to the families that need it. The health education and promotion to keep kids' ears healthy is really a lot of fun. They make it a lot of fun for their kids and bring the local families in with lots of input from the Aboriginal health staff and the community members. And here are some of the Aboriginal health staff and community members doing the screening, so they have a screening program as well. They do a lot of training with the community health nurses, Aboriginal health workers in screening assessments. So they're the ones on the ground interacting with families. They'll do the scheduled assessments, but also opportunistic. So whenever a family's coming in for one thing or another, hearing is encouraged and offered, hearing screening. Why this works, this program is the whole of region, a very strong coordination. They don't actually have a paid coordinator, but there's a lot of passion in the team, and they try to get some strong coordination, and they have got strong coordination going, which is key. It's an ongoing challenge, and the input from Aboriginal health staff has been really important. That Anne Marnie has spoken about this multiple times. They have a number of Aboriginal health staff, and with strong links back to their community, of course, but also really strong input into the planning of the services and the way it runs. Also, strong focus on keeping kids well, rather than trying to patch things up later on. And really good support from specialist service if needed too. So there's a lot of work. That's very easy to say, but there's a lot of work around all of that. Some of the dedicated staff, Anne Marnie, of course, is involved, but also she wanted mention of Beck Way and Letitia Mongu, who have put a lot of extra time into this work. So they're just two of the teams in WACS who work. There are lots of other teams, and I think we're going to hear from one of them after me. I think Joe's going to jump up and talk about the Kimberley situation. I know that the SWAMs, Ray's going to talk about what happens in SWAMs, because I should acknowledge SWAMs do a lot of key work, WACS much less so, with Aboriginal families in, well, there's a partnership, there's a strong partnership, I'll leave it at that. But it looks different in every part of WACS and every part of WA, really depending on the demographic, on the local providers, on the geography. There's a lot that needs to be sorted through, and our staff are very experienced at dealing with that. And I just want to close by acknowledging the dedicated teams and acknowledge all the WACS staff who deliver the screening programs. It's a huge effort. Any questions?
Sharon, great presentation, thank you. A quick question, which is not necessarily the early childhood space, but lately in the press we've seen a lot of stuff around juvenile justice. What role does WACS in the regions have in terms of that connection with juvenile justice, particularly around e-health and doing any screening for these kids that are first contact with juvenile justice? So we know that when, in certain parts of the country, the higher rate of hearing loss in particularly adult populations in the justice system. What about the juvenile space? Is there anything that WACS is doing in that?
More generally, I can't answer that specific question, but I can get back to you about that. Certainly, we have community health nurses based in each of the public high schools in WACS. So they're where they come into contact with children, be they involved with the juvenile justice or not. The young people, they'll certainly provide services, not just hearing, but all sorts. But that question I'll have to take on notice. Any contributions from anyone who's involved with the programs?
Thanks, Sharon, for a nice overview and demonstrating some of the successes. You did highlight some of the challenges as well, and one of them is staff turnover and training and getting people confident in examining ears, and I think that came through in that talk about the Kimberley as well from health practitioners. What do you sort of see as the model going forward? Do you think how can we best help people who are trying to do it under difficult circumstances to provide them with the support they need?
Well, we've got something of a structure in WACS, which is the staff development nurses and managers, and we do have stable teams in each of the regions, but also turnover in some regions much more than others. But even in places like Albany, where I was this week, there's something of new staff always coming, or frequently coming. We're about to try and work with Hearing Australia to look at some training, particularly around otoscopy and tympanometry, to see if we can get training rolling through the regions, and in an organised way. They do that already, but in an organised way that links up with our WACS staff, so that we, that rolls through more in an organised and coordinated sort of a way. yeah, there's some people, like Joe, put in a lot of time working with new staff, and they have a lot of new staff. Other places, it's less of an issue. Did I see another hand go up?
Yeah, so I've got a question, and obviously you've spoken about rural health and that's where you are, but do you think that something like coordinating the immunisation programs with nurses, so let's say immunisation nurses, having those skills in urban areas as well, because obviously we're missing a significant portion of the population who are now urban and coming, let's say, to a GP clinic to get immunised. Do you think that would be something that would be a beneficial rollout moving into the urban areas?
It's possible. I think it's probably worth exploring, and certainly exploring with the local communities who use the services and who should be involved with the conversation. So I think, you know, I don't know if there's anyone from CARS here that would like to comment on that.
Statistics in some communities look great, but some of the kids that have bad knees and are at risk only go to school. So we've got to change our model a little bit where, okay, we are screening schools, we're screening at the childcare health centres, but we also got to do things in the community as well. So having events like, if there's a footy tournament, getting the people out there screening kids together at the footy tournament. They're putting on a feed, so making it enjoyable. So it's changing up the model so we're actually targeting those kids as well. And if there's an adult that wants to do this, let's just be adults as well. Yeah, fair enough, it's not quite part of our funding. It's just who cares. So get the families involved as well. And that part of doing those sort of things is that we've got the families involved, so you actually educate the families as well.
Yeah, that's a great point. And in the WACS, both Narrogin and Northam, they've done that. They've gone along to specific events for Aboriginal families and offered ear health screening, which, you know, it's just a few, but we get a few that they hadn't seen before. So yeah, you're right. Find out what the family's going to respond to and what's accessible for them. Thank you. Just one more hand at the back, is that? Last question or comment?
I'm in childcare, and I find that there's a few challenges. One is that the roles expand rapidly, so you add more onto that role. And also that at the length that's involved,
Can you put the mic
often those visits, you know, to give them an immunisation and do a hearing check. On a lot of the clients won't stay for that amount of time. That they have enough. Yeah, just getting someone to engage for that amount of time is very difficult, and you need to really keep bringing them back. You know, it's all right saying do them with the immunisation, or do them with the health check, or do the health check with immunisations, but it's
so the program in Kalgoorlie, it's not the child health check, it's actually the immunisation visit. So they're coming to the immunisation clinic and getting their ears checked. So it's not the child health nurses universal contact. But I do acknowledge here there's a lot that child health nurses are expected to do, hearing checks just being one. My
Comes down to the journey. So our immunisation rates are through the roof. Then our year health checks through the roof, and getting everyone involved to make the journey. So while we've captured the all getting and it's a team of 3 people that go into that room, and that's how we do it. I just want to acknowledge too with the Archo. So Aqua and Hearing Australia also provide us with lots of training, which is really good. So we just have to get that back in now post-COVID and get all our pathways onto it. So we do have lots of support through Archos as well, through Hearing Australia and Aqua.
Thank you very much.